everyone. My name is Kina. Thank you to everyone that is here today for our July 2025 Global Grand Rounds. As a friendly reminder, we will be recording this presentation and uploading it to our YouTube, and we will also be producing an AI summary for you. Feel free to turn on the closed captions throughout the Zoom recording, and it's on your Zoom bar to follow along with today's presentation. And now we have our medical director, Dr. Pecchia, who will be introducing today's speaker, Dr. Achoru.
Thank you, Kina, and also to your cohorts and volunteers of Global Offsite Care running and organizing these global grand rounds. And thank you also for asking back Dr. Charles Achoru, who has been with us before, and we very much appreciate his presence today at our global grand rounds. As medical director, I'd like to walk you through some of the background of Dr. Achoru and what we're going to be talking about today with him. Dr. Achoru earned his Bachelor of Medicine and Bachelor of Surgery, MBBS degree from University of Maiduguri in northern Nigeria in 2010. Makes him a very young doctor, and we appreciate that youth and enthusiasm. He completed his one-year mandatory housemanship and went on to pursue his residency in internal medicine at Jos University Teaching Hospital in Nigeria. In 2015, he was appointed senior registrar in internal medicine with a subspecialty in neurology. He became a consultant neurologist at Jos University Teaching Hospital after earning fellowships from both the West African College of Physicians and the National Postgraduate Medical College of Nigeria, and both internal medicine and neurology in 2018 and 2019, respectively. Dr. Achoru further advanced his academic credentials by obtaining a Doctor of Medicine degree in clinical medicine from the National Postgraduate Medical College of Nigeria in 2023. Currently pursuing a master's in public health at Ahmadu Bello University, Zaria. Dr. Achoru actively conducts and collaborates on research in various fields, including stroke, Parkinson's disease, seizure disorders, and HIV medicine, which we'll hear a little bit more about today, pertinent to that topic. In addition to his clinical and research work, he is involved in the training of medical students and resident doctors in North Central Nigeria. He's happily married to Evelyn, a psychiatry trainee, and they are blessed with 2 children. This lecture explores clinical features of the pathogenesis management of HIV-associated dementia and severe manifestation of HIV-associated neurocognitive disorders. Using a detailed case study, Dr. Achoru highlights diagnostic challenges, neuroimaging findings, and the impact of limited healthcare resources. And we'll be talking a bit also about how that challenge underscores the role of telemedicine in improving care access and outcomes in underserved regions, which aligns well with the Global Offsite Care mission of telemedicine for the underserved globally. So with that, welcome again, Dr. Achoru. Looking forward to your presentation, and thank you again.
Thank you very much, Dr. Pecchia, and the entire team of Global Telemedicine. Thank you. Okay, so I'll start my presentation. As Dr. Pecchia rightly mentioned, we'll be talking about HIV-associated dementia and neurocognitive defects. Okay, we're talking about HIV-associated dementia. I'll start with the case presentation. Okay, our index case is a patient named, who is 50 years old, male, and worked as a truck driver. He presented with complaints of progressive cognitive decline with worsening slowness and loss of interest in previously pleasurable activities, as well as gait impairment that had been on for over a year. The disease had progressed to a state that had become completely dependent on relatives or activities of daily living. On examination, he was found to be clinically wasted and had lost a lot of weight. On a mental state examination, he was found to be cognitively slow and had a mini mental score of 12/30, which is it suggests profound cognitive and memory impairment. Also had increased spasticity across joints with an ataxic gait. He had no fever, neck stiffness, or focal neurological deficits. Other systemic findings were predominantly non-contributory. Investigations revealed that he had a CDV count of 108 cells per microliter of blood, which was quite low, and a viral load of 259 copies per microliter. It was negative to hepatitis B, C, and had a negative VDR, a non-reactive VDRL test. That's a test for syphilis. He had normal kidney and liver functions. A lumbar puncture then showed a normal glucose and protein. It was also negative for Indian ink, as well as negative for all cultures that were available here, and they had also a negative VDRL. He had initially done a brain CT with which he presented to the hospital. That showed periventricular hyperdensity extending towards the vertex of the skull. We repeated an MRI on presentation, and it showed brain atrophy with a periventricular white matter intensities and no mass lesions. Typically, this is what he presented with a lot of white matter, periventricular white matter changes as can be seen in the MRI. So we made an assessment of HIV-associated neurocognitive defects and then worked with the infectious disease team to optimize his therapy and commence his rehabilitation. Introduction. HIV was first discovered in 1981 in San Francisco, United States, and it's a disease that is known to infect the nervous system early in the course of the disease. The United Nations, through the United Nations AIDS, estimates that worldwide about 39 million people are currently living with HIV virus. Of these, 38.6 million are adults and 1.4 million are children. Overall, since the onset of the disease in 1981, about 75.7 million people have been infected with the virus. It is estimated that 42.3 million people have died, and that's quite a large number, almost equal to the populations of Canada, equal to the population of Spain, equal to the population of Morocco, and in the US, equal to the population of California as a state. In terms of the severity of epidemics, HIV is listed as number 3 behind Spanish influenza and the bubonic plague so far. However, all is not gloomy. On a brighter note, it is the United States in a 2019 statistic reveals a 23% decline in new infections of HIV, as well as a 39% decline in mortality, suggesting increased awareness of the disease, about the disease, and suggesting that increased number of people are having access to treatment and care. Now, HIV manifests with various degrees of cognitive impairments, ranging from asymptomatic neurocognitive impairments to mild cognitive impairments, and then to HIV-associated dementia. In other words, it is a spectrum. And that spectrum is known as HAND, or otherwise known as HIV-associated neurocognitive defects. The burden of dementia is worse in sub-Saharan Africa. Of course, the burden of HIV on its own is worse in Africa, where about 65 to 70% of the total number of patients are located. By way of pathogenesis, HIV is neurotropic in the sense that it has affinity for the central nerve, for the nervous system. It is also neurovirulent. In other words, it produces a lot of pathogenic effects on the central nervous system. Overall, it is estimated about 10% of patients that are diagnosed of AIDS would have some form of neurological complaints at the time of diagnosis. And then about 40% would have some neurological symptom or complication throughout the duration of the disease. Autopsy specimens reveal that about 80% of patients who have died of HIV have some form of neurological involvement. The severity of the nervous system involvement in patients who are affected by HIV is defined as neurosusceptibility, and it depends on a whole number of factors, including the host age. It's said to be worse with people who are older, genetic polymorphisms. It's also affected by the level of immunosuppression, being more common in people with advanced stages of the disease, as well as with patients with concurrent infections, including tuberculosis. Now, the exact mechanism by which HIV penetrates the nervous system has remained a topic of debate over the years. But what is known is that HIV penetrates the central nervous system early in the course of the infection. And it uses its receptor, the CCR5 receptor. We know HIV has 2 predominant receptors, the CCR5 and CXCR4. The CCR5 is used for neuroinfectivity early in the course of the disease, while the CXCR4 is used late. As a matter of fact, some studies have shown that individuals with mutations in the CCR5 gene tend to be protected from the neurological effects of HIV infection. Now, it replicates actively after infecting the nervous system and establishes latency there. And this is of key clinical importance because that has resulted in difficulties in finding a cure. Now, there are several theories that have been proposed to explain the mechanism by which HIV virus gets into the nervous system. One of them is the fact that HIV is believed to directly affect and infect the neurons, and then as such travel upwards, as similar to what you see with herpes virus as well as rabies virus. However, this is less probable given the fact that the CD4 receptors, the CCR5 and CXCR4 that have been mentioned, are not present within the neurons itself. So it's quite debatable that the HIV directly infects neurons. Also, another postulated mechanism is via direct hematogenic pathway. It is believed that the free particles are able to cross the blood-brain barrier and then gain access into the central nervous system and then establishes pathogenicity. However, this is also strongly disputed, as the virus itself has been found not to be able to cross. It doesn't avidly cross the blood-brain barrier on its own, unassisted. And this has led to the third mechanism, that's penetration through infected monocytes and macrophages, what is known as the Trojan horse theory. Several evidence exists in support of the Trojan horse theory. One of them is the fact that these infected monocytes and macrophages secrete matrix metalloproteinases, and these are found to compromise the integrity of the blood-brain barrier, aiding and facilitating the egress of these cells into the CNS, and as such establishing their pathogenicity. Also, it has been found that the HIV, one of the proteins in the HIV cell, known as the TAT protein, is believed to activate endothelial cells and result in the expression of lots of cytokines. And these cytokines are believed to, on their own, compromise once more the blood-brain barrier, leading to egress of the virus into the central nervous system. And the third mechanism has to do with the drug natalizumab, which is a medication used to treat multiple sclerosis. This drug prevents the egress of white blood cells into the central nervous system. And it has been found that in experiments, mice and other animals who were given natalizumab did not show the presence of HIV in their nervous systems. So these three explanations, or these three factors, have led to an increase in accepting the probability that the virus most likely gets into the central nervous system via the Trojan horse theory. Now, the effect of HIV on the nervous system is thought to be both direct and indirect. What is known is that several proteins present in the cell, in the HIV envelope itself, are not only directly toxic to the central nervous system, they are believed to stimulate an inflammatory response, which end up with deleterious effects on the nervous system. The direct effects is usually mediated by HIV proteins known as TAT and GP120. These two proteins are believed to arrest cell cycle arrest at the P24 level, and result in apoptosis of the cells as well as neuronal damage. Indirectly, the HIV virus is through its proteins GP41 and 120, as well as TAT, REV, NEF, and VPR, are believed to increase the concentration of inflammatory cytokines within the nervous system. These include interleukins 1, 6, as well as, very importantly, tumor necrotic factor alpha. In the same vein, they reduce the concentration of anti-inflammatory cytokines, interleukin 10. And once more, this inflammatory damage is believed to play a role. The pathologic hallmark of neuro-HIV disease, of HIV-associated neurodementia, is what is seen in the middle of your screen, is a multinucleated giant cell. This giant cell is caused as a result of the fusion of macrophages and the microglial cells. And other hallmarks in brain atrophy on gross examination. And then histologically, there are loss of myelin sheaths with myelin pallor. Now, HIV-associated dementia is found in about 20% of HIV/AIDS patients. Now, in the presence of HART, that's in the presence of current treatment known as highly active antiretroviral therapy, the prevalence of the disease is found to have slightly dropped to about 5 to 10%. And what it causes is a subcortical type of dementia, similar to what is seen in Parkinson's disease. And it's associated by psychomotor slowing and those symptoms, different from what is seen in Alzheimer's as well as frontotemporal dementia that cause mostly cortical forms of dementia. And these are a result of cortical pruning that are hallmarks of the disease. The prevalence of the disease in Kinshasa has been found to about 8.7%, while studies in Nigeria have estimated it to be about 12%. Now, as mentioned earlier, HIV-associated neurocognitive defects is a spectrum that progresses from an asymptomatic neurocognitive impairment to a mild neurocognitive deficit, and then down to the end of the spectrum to what is known as HIV-associated dementia. This is not the Frascati criteria or Frascati grading of the disease. And the cognitive domains predominantly affected have to do with concentration, memory, attention. And then very importantly, because it's subcortical, psychomotor speed. Later on in the onset, in the progression of the disease, we start to see language as well as sensory perception distortions. So I've said it is a spectrum, and that progresses from mild to moderate and then to severe. Now, clinical features are usually those consistent with subcortical dementias and include mental slowness, difficulty in learning and appreciating new things, with a memory loss, confusion, and difficulty in finding words. And then they have apathy, a form of loss of interest in previously pleasurable activities as seen in our index patients, and then eventually depression. Now, as mentioned, risk factors for HIV-associated dementia, as with other forms of dementia, include low levels of education. We found that patients with lower levels of education are at risk of cognitive defects from multiple causes, including Alzheimer's disease. Also, early immunosuppression in the course of the disease. A lot of patients who are HIV positive present late. As a result, the CD4 counts are seriously depressed, and these patients are at greater risk for developing HIV-associated dementia. Also, those with HIV at an older age, the presence of inflammatory cytokines that are found to cause neuronal damage, such as human necrosis factor alpha, hypertension and dyslipidemia, as well as apolipoprotein E. We find that the last three risk factors mentioned are also potent risk factors for vascular dementia. And it's not surprising considering the fact that HIV affects the subcortical white matter, similar to leukoarosis, a form of vascular dementia. And it is thought that both dementias may actually be related and occur pari passu. So patients who have HIV and hypertension are such at greater risk. Now, the staging of the disease, at stage 0, the patients are relatively normal, and the patients themselves, as well as their relatives, hardly notice any problems at all with the patients. So you only pick this by usually performing neuropsychometric tests that we'll mention shortly. At stage 1, they're able to perform almost all activities except for the most complex of them. And at this point, they tend to have reduced performances too at neuropsychometric testing. Stage 2, the disease at that point is moderate, and they're able to perform basic activities of daily living, such as attending to the bathroom needs, cooking, feeding, and all that. But more complex activities like grocery shopping, driving, and all that, what are known as instrumental activities of daily living, become more affected. In the severe form, they are more intellectually debilitated and usually depend on relatives for basic activities like walking, eating, and all that, just similar to what index patients presented with. And then finally, at the end stage, the patients are vegetative. Usually communication at that point becomes a problem, and they may be paraplegic and paraparetic with fecal or urinary incontinence. At this stage, we all know that HIV-associated dementia is on its own and its defining illness, and a stage 4 disease using the classification of HIV-associated disease. So it's quite common to, at this stage, see them with other comorbidities related to HIV, tuberculosis, pneumocystis jirovecii, pneumonia, and so on and so forth. Now, there are several neuropsychometric tests that can be done to pick up this disease at earlier stages. We have, for motor ability, we have things like the finger tapping test or the groove pegboard test. For concentration, we have the train making test as well as continuous performing tests. And then for processes, the train making test is also useful. And for memory, we have the Wechsler memory scale as well as the California verbal learning test. For abstraction, the Wisconsin card sorting tests, as well as for speech and language, the Boston card naming test. Now, very importantly, various centers have various neuropsychometric tests that they apply to their patients. And again, these tests are dependent of environmental factors like what is easily readily recognizable by the level of education and all. As they may vary from center to center, from country to country, what is used. Now, the treatment primarily involves the optimization of antiretroviral therapy. Now, HIV-associated dementia is listed as a reversible cause of dementia, unlike what we see in Alzheimer's disease or Parkinson's disease or Lewy body dementia. So the implication is that, or the feeling rather, is that patients who are optimized on highly active retroviral therapy, who are able to attain improved levels of CD4 count and reduced levels of viral load, eventually improve. Unfortunately, this is affected by what is known as the CSF escape. As mentioned earlier in the pathogenesis of this condition, the disease establishes latency within the central nervous system, and it is able to mutate into the various forms and escape suppression by the highly active antiretroviral therapy. The implication of this is that even when the viral load is suppressed in the periphery, it may continue to, it may not be so in the CSF. And this on its own may lead to continuous inflammation and neuronal damage happening there. Also, because the disease is a spectrum, it presents with other symptoms. Other management options include the treatment of other side effects that they may have, or rather of other complications that may have, like depression and psychotic symptoms. Now, the use of antiretroviral drugs, unfortunately, many of them do not have adequate CNS penetrating efficacy. Now, Sandra et al. Had attempted to classify the highly active antiretroviral drugs based on their CNS penetrative efficacy to see if they could result in viral suppression within the central nervous system. And he ranked them as from 1 on a scale of 1 to 4, with 4 being those that are actively able to penetrate the CNS and cause viral suppression, and 1 being the least. And the aim or the objective was that physicians and clinicians managing HIV could optimize the selection of these medications in such a way as to ensure that those drugs with greater CNS penetrative efficacies would be chosen for patients who have CNS symptoms. Unfortunately, this hasn't really come to fruition as a result of several factors, one of which being that the side effect profile of these medications were not taken into place in this ranking. As such, again, the objective of highly antiretroviral therapy is to combine drugs from various classes to optimize viral suppression, as well as reduce the chance of resistance. More work needs to be done in this area to see how the pros and the cons could be balanced. Now, there are several trials that are going on other medications. One of the several other medications, such as the monoamine oxidase inhibitors, the selective serotonin receptor inhibitors, lithium, and valproic acid. These have all been tried to see if they could affect the multiplication of the virus within the CNS, the central nervous system, but have shown very little efficacy. Minocycline is known to limit apoptosis induced by viral proteins GP120 as well as GP41. And it's still being tested with them. It showed good efficacy in vitro, but is yet to show so in vivo. Then again, Maraviroc has also been tried. Even though it shows good response, it unfortunately is limited by poor CNS penetration. Now, unfortunately for HIV-associated dementia is a diagnosis of exclusion. We know patients with HIV present with a plethora of HIV manifestations that affect the brain. As such, it is impossible to rule out some of these conditions. And one of them being Alzheimer's. In older patients who have HIV, it's important to rule out Alzheimer's disease as well as frontotemporal dementia. Also, neurosyphilis. We saw in our patients, we did various tests to try and rule out syphilis. And as well as other clinical conditions that have become increasingly popular with the advent of HIV, and those include CNS toxoplasmosis, the primary CNS lymphoma, progressive multifocal lymphoencephalopathy, and various forms of meningitis. When we talk about Alzheimer's disease, we know this is the most common form of dementia globally in aging people. It presents more of in the elderly and leads to memory loss initially, unlike patients with HIV-associated dementias that tend to present ab initio with psychomotor slowing. So this, unlike HIV-associated dementia, is a cortical form of dementia, and as such, the presentation is quite different at the early stage. And then again, the neuroimaging shows us brain atrophy that has this typical pattern that occurs mostly in the temporal lobe and the hippocampus. In frontotemporal dementia, just like HIV dementia, it is a cortical dementia, and the presentation is slightly more different. They tend to present with problems with memory too, as well as frontal lobe symptoms that include apathy and withdrawal and speech problems. Also, they could present also with behavioral problems. And just like with Alzheimer's, the MRI in this patient as seen in this image shows loss of cortical volume that affects mostly frontal as well as the temporal parts of the cortex. Then we have the primary CNS lymphoma. This is a very important differential for this condition, as it is also an AIDS-defining condition. This is caused by the Epstein-Barr virus and tends to affect mostly is usually found around the white matter. Now, it tends to present as a solitary mass that is ring enhancing, and it's becomes more prevalent as the HIV infection progresses and the viral load declines. Now, very importantly, to differentiate this from the dementia, from the HIV, it is high, as we rely on it, high association with Epstein-Barr virus. As I've said, 95% of cases are associated with Epstein-Barr virus. And very importantly, again, also, it's the mass effects, the fact that it presents as a mass on the HIV-associated dementia that is classically not presents with atrophy. Then we have another common condition, what is known as CNS-associated toxoplasmosis. It is caused by the known as Toxoplasma gondii, that is gotten from close contact with domestic pets, especially cats, and their feces. Now, they result in the formation of bradyzoids that become reactivated once the immune system is suppressed by HIV virus in advanced disease. This also is an AIDS-defining condition and tends to be more prevalent as the CD4 count drops below about 100 cells. Now, what it does present with symptoms of because it's also subcortical, symptoms of psychomotor slowing, they tend to have seizures as well as focal neurological deficits. Now, MRI shows multiple ring-enhancing lesions, usually located around the basal ganglia, as seen in this image. And another very important thing to note is that this condition responds avidly to treatment, especially using sulfadiazine and pyrimethamine. And then we have the progressive multifocal leukoencephalopathy caused by the John Cunningham virus. Now, this virus infects oligodendrocytes. Oligodendrocytes are responsible for myelin formation in the brain. And damage to these cells results in demyelination and white matter changes similar to what we see in HIV-associated dementia. The presentation is usually as insidious mental, visual, and speech changes. The difference between this and HIV-associated dementia on imaging is that this presents as usually subcortical lesions that usually do not non-ring enhancing with contrast. Now, what are the local challenges we face in Nigeria as well as other developing countries? As mentioned earlier, HIV-associated dementia is a diagnosis of exclusion. As such, you have to rule out other conditions. And this causes a problem because you need to do sometimes multiple modalities of neuroimaging, including CT scans and brain MRIs. You might need to do a lumbar tap to rule out certain other infections. Now, challenge in our environment because access to some of these things are relatively scarce, especially in the rural areas. It's somewhat difficult to make a definitive diagnosis of this. Also, we know that a lot of patients in our environments who have HIV present very late to the hospital, and this is caused mostly by a result of stigma. So with this, we tend to have patients presenting late. So a potent risk factor, as mentioned earlier, for HIV-associated dementia is worsening CD4 values. Unfortunately, we're not able to pick them up at points where we can actually get a hold of the disease and prevent a further decline in CD4. Also, there are conditions that are generally applicable to almost all developing countries, and this includes inadequate staffing. Our doctor-to-patient ratio still remains a little bit abysmal. And with poor funding, we are seeing a massive wave of brain drain with doctors in poor settings relocating. We have inadequate facilities. Okay, poor funding has resulted in a shortage of facilities, and sometimes patients have to travel a long distance, kilometers and miles in some cases, in order to get access to the nearest healthcare facility. Also, we have very limited centers that carry out advanced imaging modalities like CT and MRI scans. In just the center where I practice, you only have to come to the state capital. You must come to the state capital to be able to access any of these things. And unfortunately, these machines tend to break down from time to time. Many patients have to even travel longer distances for them. There are limited availability of medications. For the past 20 years or thereabouts, HIV medications had been available as a result of interventions from the United States, PEPFAR. There's presidency program for AIDS relief launched by former US President George W. Bush. But unfortunately, funding has continuously declined over the years and has virtually collapsed with the defunding of the US AIDS program. So what we're seeing is patients would now have to pay from pocket, or African governments will have to take over the responsibility for this treatment. So we're having a lacuna that is yet to be filled. And we're unfortunately hoping that the control and the benefits that we have in terms of HIV control that have been achieved over the past 15 years are not lost. And then we also have limited access to treatments. Again, more or less a compilation of all the other challenges that I've mentioned. Now, how does telemedicine come in? Very importantly, we've mentioned that the medical facilities are quite scarce and very far from our patients. Now, telemedicine can, as much as possible, bring medicine closer to the patients. It is very important for us that this happens so that it can assist us in early diagnosis as well as early treatment of these patients. Very important in our environment, internet facilities tend to be a little bit more available than hospitals and diagnostic facilities. So the telemedicine can actually play a key role in this. Also, increased speed of consultation of these patients as well as referral and sharing of information. Even I, as a neurologist, can see a patient and then share with a pulmonologist or an infectious disease physician. Should we need to collaborate? For, in most cases, management of HIV-associated dementia is a multidisciplinary approach and would require assistance from other health care teams. Also, better linking and access to treatments. Patients would not only have access to HIV treatments, should they need tuberculosis treatments, we could be able to link them up to the TB center using telemedicine to get this done. And very importantly, a key role in HIV prevention and advocacy. I've mentioned that over the past 15 years, there's been a gradual decline in incidence of HIV infection. And this has been attributed to improved information sharing, improved knowledge, safer sex practices, better prevention of mother-to-child transmission of HIV disease. And very importantly, telemedicine can help spread this message to the grassroots in multiple languages in such a way that even with reduced funding, the advocacy and the message still continues to get to the targeted audience. Thank you very much. We've learned that dementia is a clinical disease with a broad spectrum that can span from being asymptomatic to being debilitating. And we know that early diagnosis and treatments can prevent its progression. As such, we need to employ whatever measures available, including telemedicine, to get the message to the target audience. Thank you for your attention.
Thank you, Dr. Achoru. That was super informative and thought-provoking. I'll lead with a couple of questions and encourage those in the session to pose a question either in the chat or directly to Dr. Achoru. There's a question that comes up basically from the public health perspective, and not knowing that you're currently adding to your list of degrees, getting your MPH. And from that perspective, given the massive scale of HIV infection and sub-Saharan Africa and Nigeria, what strategies might be able to be leveraged through telemedicine at scale to address prevention, early detection, and treatment of HIV-associated dementia? And I'll clarify that by noting that you mentioned that the incidence of HIV in Nigeria, if I got it right, is 12%, and that those who are taking antiretroviral therapy have 5 to 10% involvement of HIV-associated dementia. So if that's a rough estimate, that half of the strategy, you can basically cut HIV-associated dementia in half simply by treating with antiretroviral therapy. Is there a path, a public health path toward getting that news out to those who either are not already treated with antiretroviral therapy that have been diagnosed with HIV, or those who are on it that may be suboptimally treated?
Yes, thank you very much. I think very correctly, yes. We can use telemedicine. I think first and foremost, telemedicine can help prevent by way of spreading the message. Telemedicine can assist us in lowering, first of all, the incidence and as such the prevalence of HIV infection first. Then among those already with HIV infection, it's very important that we make sure that as many people as possible are on treatment and very important they are adequately treated. And by adequately treated, we mean with viral suppression and optimization of their CD4 count. These factors together have been shown. We have a problem here with regards to adherence, poor adherence to therapy. That's another way in which telemedicine can come in. We can preach adherence to them. We can have multiple meetings or multiple sessions with reminders, because sometimes people need to be reminded from time to time, especially when they're in educations with less education. Yes. So we may need to teach them on a mass scale. We may need to work with community leaders, because in Africa here, lots of communities are enclosed more or less. So you may need to work with community leaders as well as religious leaders to spread the message. Very importantly. Yeah.
Thank you. Appreciate that.
Thank you.
Other questions, concerns, comments? We have just a few minutes before our time expires. We have Dr. Benninger, raised hand. Dr. Benninger.
Yeah, lovely. Thank you for that presentation. I'm only disappointed that there wasn't more people being educated by this presentation. Very informative. I was very pleased with your rhythm and just all the information, the update, which is terribly important. You mentioned this Trojan horse third concept or theory about how it crosses the blood-brain barrier. Interesting that at one time we didn't really, when I say we, I guess the medical world, especially in anatomically, didn't really think there was a whole lot of lymphatics going on within the brain. And now we know that not to be true. And this Trojan horse thing, do you think that's surpassing the number one theory, at least with modern day scientists? What's your feeling on that?
Yeah, I think, yes, I think I agree that that's the most probable theory. There might still be something else might come up in the future, but I think given the body of evidence out there, I think that's the most probable.
Yeah, and I just want to make sure I understood clearly. Not only is this type of dementia that occurs, I did hear you, and obviously it's very obvious that it can be treatable. When you say that, at least in your hands, when you see various patients like this, roughly what do you expect to be the end outcome 6 months down the road?
Okay, it varies in all truth and honesty. Treatable because theoretically it's believed that the cause, which is HIV infection, is in response to treatment. Okay, but from experience, actually, not everybody returns to pre-morbid conditions. No, not everybody does that. Yeah, we do see some improvement, yes, down the line, but most usually do not return to pre-morbid conditions.
Yeah, and if Dr. Pecchia doesn't mind if I take up one more question. The other thing that was, when they return, what do they return to? Are they still needing full-time care? just because they improve a wee bit, I know scientifically we can say, oh, they improved X or whatever, but functionally, do they actually improve to where they bathe themselves, or they can feed themselves, or they have certain kind of memory where they remember a person's face? What is that when they return? And is there a pattern of what type of person typically does well? Female, is it male? Is it under 80, under 40? Is there a certain demographic that you find seems to be a reoccurring theme?
Okay, thank you very much. Yeah, when they reach, let's not forget that on its own, HIV-associated dementia is defining. So unfortunately, some of them have other comorbidities associated with the HIV infection. That is a problem. Okay. Yeah. So when they return, some of them may return to being able to live independently. But again, that depends on a number of factors. Is it just the HIV-associated dementia, or are there other things, other comorbidities affecting? And again, that goes to your second question. It depends on the premorbid state. What was the CD4 count? The viral load. There are people who come in with abysmally low CD4 counts. We've had sometimes single-digit CD4 counts, 8, 9. So those patients typically do not do well. Again, older patients do not do well. Patients with comorbidities also, hypertension, diabetes, and all that, because they tend to have some of the components of dementia, like vascular dementia. Some of them may have had some form of minute strokes in the past that contributes to cognitive decline and neuronal deterioration. Yes, ideal patients, the younger patients who is newly diagnosed, preferably coincidentally diagnosed without symptoms, and then we find on psychometric testing rather than clinical deterioration some features of cognitive decline, and are able to start and initiate treatment. Those ones are most likely to return to full function.
And you mentioned viral load as a factor. Is there a threshold where if it's higher than X, you're very concerned that they're probably not going to do terribly well, and if it's lower, then there's a chance?
Not really. No, there's really no threshold. Our objective is to ensure that the viral load is suppressed to undetectable limits. Yeah. Once the virus starts to appear, we get a little bit worried that control is not optimal.
Yeah, thank you again. Honestly, I thought this was incredibly informative. I can't thank you enough for this case presentation, but really everything around the case itself. So thank you so much.
Thank you very much, sir.
Yeah, thank you, Dr. Benninger, for that, and Dr. Achuro for expanding on some additional dynamics of how to address this massively important issue, not only in greater Nigeria, but globally. If you do the numbers, we're talking about millions of people globally, and leads to my final question, which is, again, from a public health perspective, knowing that the World Health Organization already has what are called syndromic pathways for diagnosis and treatment, specifically for sexually transmitted infections, for individuals who are afflicted with conditions, STIs that may occur in areas that are resource limited, meaning that they have no testing, but they simply have symptoms, and that there is a pathway for treatment based on symptom diagnosis alone. And especially given that HIV is certainly, in many cases, a sexually transmitted infection, is there, to your knowledge, and certainly I'll be taking a deeper dive on this myself, a syndromic pathway and evolution for the treatment of HIV-associated dementia in communities that are resource limited?
Okay, yes. There's a pathway for both diagnosis and treatments of not just HIV-associated dementia, but HIV on its own. We have WHO case definitions for HIV, 1, 2, 3, 4, with HIV-associated dementia being stage 4, WHO stage 4. Now, for the dementia its own, not really. There's really not a case definition. Again, because it's a diagnosis of exclusion. So we need to exclude a lot of other things before we do it. Now, the main goal in the approach to patients with HIV-associated dementia is to suppress the viral load and optimize CD4 count. And then with respect to that, again, there's a WHO for resource poor settings. There's a WHO, should I say staging or the use of antiretroviral therapy? Okay. There's a first line, second line, and third line. Okay. That's based on one, efficacy and cost, very importantly. So we don't just start patients on medications as is done in resource-rich settings. What we do is that there are first-line medications that are used, and then should that not be optimal, patients are switched to second-line, and then really third-line medications. Yes. And again, once more, the aim, as I said, is to suppress the viral load and improve the CD4 count. That's the first step in treating the condition.
Thank you, Dr. Achuro.
Thank you very much.
You got okay. We'll wind up against our hour, the end of our hour. And again, thank you so very much, Dr. Achuro, for sharing with us again today, and looking forward to the next opportunity. And also for those who are able to attend this morning, you may want to pass along, due to a meeting ID issues this morning, we'll go ahead and record this as we always do, and post this and include a summary on our website. And I'll work with Kina to be sure that all of you receive a notice of that, and feel free to share this session with those that you feel might be likewise interested. With that, again, thank you so much to our speaker today, and back to Kina to close.
Thank you, Dr. P. And thank you so much, Dr. Achuru, for your amazing presentation. And thank you to everyone in our audience as well for your continued interest and participation in the Global Grand Rounds. Our next Grand Rounds will be on August 12th at 8 a.m. as usual. And if you are interested in presenting, please feel free to reach out to us. And thank you all, and have a good rest of your day.